Anybody any doubts? I'm the man, not the woman, okay, in the title. My name's Mike Lewis. I'm fortunate, I've just had my exercise today by running up and down from the back and the front of the hall and going out to lunch. I'm chair of 5 medical companies, biotech, healthcare, neuropsych. I chair the Assisted Living Innovation Platform, the KTN Health Board as well, and a load of other stuff like the Biomedical Catalyst. But one of the fun things is I've actually only lived in this country 2 out of the last 25 years. So I've been outside this country, living in such wonderful places as Switzerland, the US, Paris, France, Lugano, Switzerland, Naples, Italy, which was quite fun, and then in Belgium, in Brussels as well. But I'm not a Eurocrat. Session today is about empowering patients. And I thought before we start, let's just check something. I'm just checking my blood glucose level. It's okay. 3.5 millimoles. I'm okay, I'm set. That was my onboard glucose sensor, which is just behind my ear. I was just checking. No, that's next year. I wanted to wake you up a little bit and give you a quick shot of a video. And maybe that'll introduce us a little bit into sort of the theme of empowering patients and what that's all about. It's quite strange, isn't it? Anybody remember when that series was from? No? 1966, 1967, they were talking about information. There's all sorts of strange themes around it. And just so you know, those round black things, they were not original cloud servers. They were just bubbles, okay? Just so you don't get too worried about that. But there's some really interesting themes around information. These guys were after information, and they were one of the key themes which came through that film or the series, TV series, The Prisoner, was all about information and collecting information for the good of the collective versus the information for the individual. And that has quite a few parallels as well in terms of what we're trying to do as we talk about big data, the panel session before, gathering data with the academics talking about things. And talking about industry as well, gathering big data. But what's the purpose of gathering big data? Is it for the good of you, or is it for the good of everybody? And there's some really interesting tussles there and fights between people about who owns data. I asked somebody just beforehand, as we went to the break, I said, do you know in this country who owns your data, your healthcare data? And they actually got the answer right. It was the very first person I've had actually get the answer right. You don't own your healthcare data. Your data is owned by the Secretary of State for Health. Thank you very much for that. It also says in your passport that you're a subject of the Queen as well, which is also very nice to know. All my data belongs to some guy in government. It's quite scary. There's themes for this meeting. We've seen the series. We talked about the subtext. It was all about information and collecting more and more information as you went through. Look at the meeting themes. There's 3 of them really. Innovative business models, empowering patients and staff, and big data. And the really sort of chunky, sexy one, I suppose you'd say, is big data. Everybody wants to know what big data is and what it's all about. So that's why it's really popular and people are trying to grasp with it. But if you think about it from the other way around, where do you build the business models from? Well, you build the business models from the big data, and those business models should help you empower patients and staff. So it's round the other way around slightly. But then you've also got to worry as well. We were talking at the back of the room about big box manufacturers. Who's driving the need to collect all this data? Is it being collected for their purposes so they could sell their technology, or is it being collected for us as patients so that we can help improve our healthcare? And we have to be really careful sometimes because the technology that can be produced is not necessarily the technology that we want or need. So you've got to do a little bit of pushback sometimes. Sometimes a nice new shiny iPhone 6 is not what everybody needs. There's a lot of elderly patients I know from my work with CCGs that come in there and say, doctor, I don't even know how to work this cell phone. That's not the technology they need. That doesn't help them and it doesn't empower them. Empowering patients and staff. There's 4 steps, really. You feel empowered when you have knowledge. And I didn't say data there, I said knowledge, and meant that specifically. Knowledge comes from, this is the neuropsych bit, knowledge comes from synthesizing information, facts, things, connections, and you put them together into some form of knowledge. The knowledge comes from the information. The information is your collated data, because the data's out there. There's a wild types of information out there and data. You have to put that together and that becomes information. That information is synthesized, becomes knowledge, and you end up with a nice virtual track of information flowing through. But data is just the raw source. Let's look at some technical stuff. As you're looking at empowerment, you have to go back and think from the technological viewpoint, where are we? Where are we coming from? And if you think about stepping back, not to the 60s like the prisoner was, but if you step back a little bit further than that, you're looking at how much processing power's improved. Because you have to do 2 things. If you're looking to gain knowledge and information, you have to do 2 things. You have to store stuff and you have to process stuff. If you store it and you can't do anything with it, it's worthless. If you can process it and you don't have enough data, that's worthless as well. You have to do 2 things. And just look what's happened in the world. Back in 1986, all the processing power, 41% of the total processing power in the world was in pocket calculators. It's amazing as well. The processing power actually I got in my iPhone 5 here is actually more than the processing power that was in Sizewell B when it went online as a nuclear reactor. There's more processing power in that. But look at how it shifted. PCs were 1/3 of the information. 84 IBM PC came out, so 1/3 of the information, Apple IIc, Apple Lisa, they're all out there. Video game consoles, they had some processing power. But then if you shift to the side, you look at the servers and mainframes, stuff was stored centrally. A lot of stuff was held centrally. And you flip that around to where we are now in 2014, and suddenly pocket calculators virtually don't exist. But most of the data is held in PCs, and surprisingly, video game consoles. That's where the processing power lies. So it's shifted significantly, and we expect to see that shift as well. The cost of processing power has come down, and we're going to talk a little bit about Moore's law as well a little bit later on. The second thing, as I mentioned, storage and processing power. That was processing power. Let's have a look at where storage has gone over the past few years. Taking exactly the same parameters, going from 1986 to 2014. Processing power was 2 ways. It was analog and it was digital stuff. And back in 86, we had about 20 million gigs of processing power stored digitally. That's gone up to 276 billion gigs of data, which is available now for storage. That's over 13,000 increase, and that's just phenomenal. Data's moved from analog to digital, and just the capacity of it has moved enormously. This gives you some things that you can do, and this will affect how patients are empowered and how data can be stored and processed. In last year, there was about 39 gigabytes of storage for every single person on this planet. So, each of you, there was 39 gigs put aside in a server farm, and that was you, your little pot, let's call it. So, what's held about you is about 25 HD movies. Sounds about right. That's 2 days worth of movies in my books. It's not bad. But it's also enough to store your genome 20 times. The average genome is very close in terms of storage capacity to what you can get on an HD movie, on a Blu-ray movie. That's you. You can get it on a little disc. It's incredible how little it takes and how available that is if you think about how storage has moved on. I always like to compare where we are with machines and humans. And one of the companies I work with is heavily into neuropsych, so we do a lot of cognitive behavioral stuff, cognitive neuroscience. But let's just have a look structurally at a human brain and a human being. We have about 86 billion neurons sitting inside our head. That's a lot of them to count. Each neuron can actually make, actively, about 1,000 connections. So one can make a connection with 1,000 others as they go around. All happening inside that little blob there, between your ears. That's about 100 terabytes of data inside here, inside this room. Everyone's got about 100 terabytes. But some of those connections are redundant and some of them can be duplicated. So if you actually look at it, what's inside a human brain, what capacity a human brain has, it's around about 2.5 petabytes of data, which is a phenomenal amount of data compared to what you can store digitally. So we outstrip stored data as of this year, 2014. We outstrip stored data by about 100 times, but good grief, that is changing. I mentioned, and a lot of people have mentioned Moore before. There's a picture of him, so you know what he looks like. It's back in 1984, I think that picture was taken. And according to Moore's law, our storage capacity, the stuff we can store offline, will exceed the stuff we can store online by about 2030. But data storage has never, unlike processing power, data storage has never adhered to Moore's law. Data storage has always been faster than Moore's law. It's consistently broken it every year if you track it. Processing power goes like this and doubles, but storage capacity more than trebles. We're more likely to exceed our storage capacity by about 2020. So, storage. We're going to have a lot more storage than we could possibly hope. Everything we know and every connection we can make as humans, all that storage capacity will be exceeded in about 5 years' time. You mentioned processing power. Here's a friend of mine, Rick Kurzweil, ex-Google guy. You probably know him. He's looked at pure processing power, and he estimates the machine speed will exceed the human speed of processing by about 2023, which means suddenly we're going to be in a world where machines can store things, process things, and do things faster than us. And I'm not going to go into Asimov and robot laws and things like that. That's just out of the air. I'm going to look at how this affects empowering. If we have the capacity to store, the ability to process, it can be liberating, but only if applied to the right tasks. We can't have this stuff shoved at us as patients, as providers and deliverers of healthcare. It can be very limiting too. Just have a look at healthcare. As you're looking at what you can do digitally to the world in terms of storage and capacity, look at what the drivers are behind a healthcare system. I like to compare, the NHS was founded back in the 1940s, Labour government. They founded it, and this is what the NHS looked like then compared to what it looked like now. Life expectancy for males has gone up from 66 to 78, females from 71 to 82. I've got no idea why females have got less increase in life expectancy than males. The population was 50 million, heading for 64 as of the end of this year. And the major challenges really for the healthcare system at that time, it was about acute treatment. It was about treating people for short-term conditions, infections, accidents, industrial injuries, etc. That was the essence of the NHS. It was a safety net there to catch you. It's moved and it's transmogrified into this thing which is about diabetes, obesity, and cancer, chronic conditions. The major medical advances back in 1948 were penicillin, and a dose of penicillin in today's prices is about £2 a dose. What we moved on to are the major medical advances in terms of stem cell therapy, spine nerve regeneration, prostate cancer vaccines. Prostate cancer vaccine will cost about £50,000 for one course of therapy. So you've gone from an environment of £2 for a treatment of penicillin for acute diseases to £50,000 for treating your oncology products. That means a lot of cost into the system. Done some good things as well. Introduced infant mortality, got that down from 42 per 1,000 births down to 4. The US is still at that level because it doesn't have prenatal care. And look at the budget. When we set back the NHS was set up, it had a budget of 437 million. Translate to this year's currency, it's worth about 9 billion. Suddenly, because of the change in NHS, it's gone up and the spending has had to increase 12-fold in real terms. And look at what's happening in the future. Look at us. We want more. We demand things. We think we're entitled. We think we're entitled to the best treatment. Technology's jumped on as well. We want care for ourselves. People are asking the questions, why isn't my medicine personalized to me? Why isn't it tailored to what I want? Why is it right that the average dose for paracetamol is maximum dose of 3 grams per day, but then somebody can be 60 kilo person, somebody can be 120 kilo person, yet the dosing's the same? Why is that? Why shouldn't it be tailored and why shouldn't it be personalized? The costs are increasing. Our lifespan is increasing as well. But our lifespan is increasing, so our productive time stays the same, marginal increase in pension age, but then the non-productive time we're alive and we're consuming health. 50% of your total costs that you will absorb, take back out of the healthcare system, occur in the last 6 months of your life. Just we haven't worked out how to calculate when that period starts, because that would slash the NHS budget deficit in a heartbeat. I think the other thing as well, for doctors and nurses in the audience, you're going to see a lot more patients coming forward with, as they come for their consultations and appointments as well, they come having studied the internet, seen what their condition is. They come with a picture of the disease and say, "Doctor, I think I've got this." Or they say things like, "Do you think my ingrowing toenail will be helped by this latest Gregorian chant therapy?" Doctors are getting asked more and more. The consumer knows more and more. There's more insight. There's more knowledge as well. They're pressurizing the system. Comorbidities are out there. They're driving it. People just don't have one disease. The average prescription in Scotland is for 4.5 items on a prescription on the FP10. 4.5 items because people live longer, get another disease, and suddenly you're into this takeoff. And we see this with the assisted living innovation platform. Suddenly you get this wave at the end, this tsunami of cost. And then you put on top of that the budgets to deliver all this, they're all restricted. We've all heard about deficits and everything else like that. So we've come from a place where the NHS was designed and built around acute therapies, it's having to move to chronic therapies, costs are changing, and suddenly the dynamics changing, and data's giving people the information to look at things. And they've all got different agendas. The patient has a different agenda to the deliverer of healthcare. The deliverer has a different agenda to the provider to the payer. The eventual payer in this country is us, because we pay our taxes. Unless you're on Boots. And the patient's agenda? They want the best care for themselves and their family because they deserve it, because they paid for it. They want to know it's there if it's needed as a safety net. They are informed about what the alternatives are. They have access to basic data about what's happening. If you go into NHS Choices, you can read people's thoughts about their doctors. Whether they're real or not, you're not sure, because I'm not sure whether it's really TripAdvisor or NHS Choices, because there's no screening of that data at all. It's not based in any relevancy. They're going to get access to more data like friends and family testing. And their agenda is moving from what you call in transactional analysis from parent-adult child, from a parent, medical person talking to an adult. It's moving to more a collegiate adult-to-adult relationship as well, and that's what they want. And I tell you, they also want to be treated now. They want instant gratification, as Bruce Keogh said. Instantly treated. I want to be treated now. If my doctor isn't open, I'm going to go where I can be treated because I know the lights are on in that A&E over there or that walk-in center. They have a service mentality. Deliverers, they want to give the best care possible. Common theme. They're pressured by bureaucracy. There is so many top-down imposed systems and tick boxes and paper filling. I sat in Bromley CCG on Friday. I was at Suffolk's, both CCGs on Monday, and I saw the mounds of paper these guys have to produce. They spend so much time doing paper stuff, they have no time to treat patients. They don't really like hyper-informed patients because that's a distraction. They're concerned about metrics and tools and transparency. They want to know about innovations, but they want to know how they're going to be paid for. And they really don't have a service mentality per se. Not like service industries I've run. They have a vocational drive because they want to do this, they want to do good. And providers, they also want to give the best care possible, but they're more coming at it from the other end. They don't see the detail, so they want to have systems and programs in place which can help them analyze what's going on and measure stuff and count stuff, because, do you know what, if I can count it, then I've got this instant gratification, I feel happy about it. I think I know what's going on. Do you really? No. They're concerned as well. No mid-staffs here, please. I put up on the board. They don't want to be exposed and put in the glare of the spotlight. They're pressured by finance and budget. They're overwhelmed by reporting themselves. And they do have generally a service mentality. Then you go to the payers. They want to give the best care possible. They recognize that health could produce wealth. The governments, the politicians of this world, they see that the better the health of the population, the more wealth they're going to get out of it. And there's good connections and good data from Europe on that. They want to drive a healthy agenda to address health challenges. They're trying all sorts of systems to squeeze out efficiency. But they have a complex delivery system, so all they can do is constantly ask for numbers and data and information, and that's their only contact point they have, the data going through. And if the data looks skewed, suddenly they start to raise flags, put people into special measures. Not because they've been to the center and seen patients waiting on a trolley in A&E, but because the numbers didn't look right as they squeezed them. So who's the driver? Who's the passenger? Common themes? Well, we know all the external ones about increasing age, comorbidity, lack of incentive to improve, lots of neurodegenerative conditions out there, lots of comorbidities, cost of care is going up. Now, how do you drive efficiency without imposing more and more systems on people and being able to deliver more for less? And sometimes one person's transparency and desire to know is another person's, don't step in my back garden, mate. I don't want you here. Brick wall. There is a brick wall coming. If you look at all the nations in the world, they've got to virtually double their spending on healthcare as a percentage of GDP, accounting for age, accounting for elasticity in demand, accounting for all the economics. There's no economists in the audience, is there? Thank goodness for that. Accounting for elasticity in demand, cost containment, specific residuals, etc. You factor this all up, you've got to double the spend on healthcare. And in this country, this is the OBR statistics in terms of what we need to spend on healthcare. We've got to increase our healthcare spending as a percent of GDP by about 50% over the next 20 years. So even though the economy is growing, the percentage of spend, they say in their budget models, and this is what it is, a budget model, they say it has to go up by nearly 50%. And do you know what? That just can't be afforded. Digital's a game changer. It empowers and enables. And there's 4 ways, really. There's 4 themes which will help us get to where we need to get to without having to spend that lot of money on there. You're talking about going from 8 to 12% spend of GDP on healthcare. Well, the defense budget's 2%, defending us, all of us, 2% to spend. So that's like double the defense budget we have to increase. That's just not affordable. We have to go much further down, develop micro mobile systems, have to take care of ourselves, and we have to have tools to do that. Personalized medicine will play a part in it, and also portability of records, knowing more about me, will help as well. We've got to bring health IT into the 21st century and go back to that theme of the individual versus the collective as well. It's not bringing big boxes to stick in hospitals, because that's not where the bulk of care takes place. The bulk of care takes place at the primary intervention with a practice nurse, with a GP, with a physiotherapist even. That's where the bulk of money is spent, not at a highfalutin hospital spending lots of money. You look at the world, we've talked about retail, people talking about how can retail impact stuff. Well, retail is the future of where health will be. 80% of holiday bookings are done online. You've seen that travel agents are closing the high street. Mostly they're replaced by tattoo parlors. UK mobiles, 92% of people have a mobile. Most people have 2. You don't need to put your hand up if you have 2 mobiles because they know who you are. Wearables. People are saying they're going to be wearing wearables. 100 million wearables by 2018. There's all these things. iWatch comes out. The Apple's iWatch, gold edition's coming out, £5,000 if you want to form a queue. Orderly line outside Debenhams, please, or wherever. But the revolution's here in other sectors. Centrally designed, centrally deployed systems have failed multiple times. Do you want me to name them? Choose and Book. Designed 2002. Deployed 2005, 2006. Maximum penetration, 51% of all outpatient appointments, 2010. Shot in the head, 2014. Goodbye, £350 million. Centrally designed system, designed, and by the time it's deployed, it is obsolete. Do you know what the average cycle time is for a refresh on an app, on iOS, or even on Play Store? It's 30 days. The top 25 apps on those stores are refreshed and renewed every 30 days. How can a central purchasing system hope to cope with that speed and that velocity? If you don't have one of these apps on your phone, I really am not going to believe you. You'll have Messenger, you'll have WhatsApp, you'll have Facebook, you'll have Instagram, you'll have Skype. Do you think these were designed by governments and by central purchasing? No, they weren't. These are agile companies designing agile systems which get deployed, get accepted, they're viral, they're endemic, and patients and people want to have them. They're not told to have them. Revolution's here in other areas. I book my travel online. I can't book my GP's appointment online. The Royal College of General Practitioners said they wanted 5% of all GP appointments booked online by this year, 2015. There were 400,000 out of 350 million GP appointments last year booked online. Why? System's clunky. System didn't work. Repeat medication results. There are nearly 800 million prescriptions done in UK, Scotland, Wales, Northern Ireland last year. How many are done electronically? Less than 2%. You've got to go into a world where, just like the apps are doing things, you've got to go into a world where microsystems, small systems come in and enable people. You've got to have the processing power in this, which everybody has. That has to become your front end. Because you're used to it, you know how this thing works, it carries with you. You have to use that as your front end access to healthcare. It's personal, it's private, it's pervasive, but it's portable. It doesn't require anything from central government to tell you what to have. There's only 2 or 3 operating systems it works on. Either one's fine. But we've also got to get, now we've got the processing power, we can address these things. UK repeat prescriptions, there's 1 repeat prescription done, sorry, there's 30 repeat prescriptions done every second in this country. 30 per second. Look at that compared to the bookings of flights on UK airlines. It's about 4 times as much. Look at the number of Ocado orders. There's about 163,000 a week Ocado shipments done for groceries. If you're going to do GP appointments, you've got to go to 5,000. There's a GP appointment set up every 12 seconds. And if you do it online, that's 5 transactions. You've got to do things which will speed things up. I go to my post office, and there's a sign in my post office. It tells me where I have to go to. Go to number 4, please, Mr. Lewis. I go there, and it has a waiting time, and I can see how long I'm going to be. But none of this exists in GP surgeries. It just doesn't exist. I have to go there, check in, or press a panel or something and go and do it. I'm walking with a detector, which is this guy, in my pocket. It knows exactly where I am and where I've been. Anybody play with Find My Phone? It's very accurate. You can geolocate where people are, and as they're approaching GP surgeries, check them in if you wanted to. You can do all that now, but it's not deployed. Why? Because it won't happen in a central purchasing system. It has to come from the ground up. People are going to want to have to do these things. Don't worry, be happy. It's a sad story, actually. Do you know the guy who wrote the song, Don't Worry, Be Happy? Very sad story. He committed suicide. He was a manic depressive, unfortunately. My health. We've got to be in a world where you take responsibility for yourself and look after technology and have direct interactions. If you don't look after yourself, who will? Are we going to be rewarded? And this is going to be challenging the NHS system. Should we be rewarded for looking after our own health? What does that mean, being rewarded? Does it mean priority speedy boarding? What does it mean? But if you're going to take care of yourself, and you're going to be less of a detractor from the system, why shouldn't you be rewarded in some way? Unless you can square that, you're in trouble. Does that mean access to treatments, reductions in costs? Don't tell me it isn't happening, because it is in North Devon, where people have been denied access to operations because they're a smoker, until they've shown themselves off smoking for about 8 weeks. Don't tell me it's not happening right now. It's just not out there in the wild. Yeah, I do. I Fitbit. I'm sorry. I capture my data. I look after it. I want to know I've done my 10,000 steps. This is me from, I think, 27th of January. Yeah. People are going to want these things. Not everybody's going to have a wearable. Come on. This is for people who like high tech. This is not the only way you can get access to it. But you're going to have to look after your own health care. If that's a wearable, great. But there's technologies out there where you can do things which are not technology pushed down your face. There's things out there which are testing, which is asynchronous appointments. So you open a session with your GP nurse, and then you can load data into it so that when you go to see your doctor, he's not having to play that guy on the left-hand side, Sherlock Holmes, and ask you all the questions. Instead of being a 7-minute transaction where 2.5 minutes are spent asking you how you feel and everything, that stuff's in front of them. They know what's happening, so they can go from Sherlock Holmes to nice doctor who cares about you. And you know what? People's mental health improves if you do that as well, if people take time. It really does work. Personalizing health, I'm not a number, I'm actually a series of numbers, about 1.44 gigabytes of numbers. Personalized medicine is going to change things enormously. That's the third thing that's going to change things. It took us 13 years to read the first human genome, cost about $2 billion. If you want your genome done now, come and see me afterwards. I'll give you a Groupon. It's about £1,000. And there's 7 impacts for that. Really on children. Most of the genetic disorders you discover are in children under 5, and that's where you want to do some work. You can stratify medication according to disease. This won't work with you. This cancer treatment will not work with you, but will work with you, so you'll get that, and you'll get something else. You can include antibiotics, because you can actually stratify people according to their genotype and find out which antibiotic will work with them. We won't need to do as much diagnostic imaging. Those big scanners, those MRI scanners costing 2 million quid sitting in hospitals, you won't need them because they are things looking for needles in haystacks. If you can see the whole haystack, who needs something to look at it? If you regularly monitor patients, if the geneticists amongst you know that genotype plus environment equals your phenotype, who you are. Your genetic makeup plus what happens to you outside in the wild world is who you are. So if you know you've got a specific genotype, then you're monitoring people for what happens in the environment so you can check and see what's happened to their phenotype. Care will be pushed. If you're working in a secondary hospital, a district general hospital, start creating your resume, because those places won't exist in the future. It'll be primary care or it'll be expert care. It'll be primary care, and your expert care might not be in your local hospital. It might be John Hopkins doing your epilepsy treatment because they're the best in the world. People in secondary hospitals, DGHs, who maybe do 1 hip replacement a week, people are going to go to specialist centers where they do them 1 a day. The DGH is just about dead. It's the dead general hospital. That's what's going to happen with genomics. You can do things as well. You've got to ask questions. Who's going to store the data? Those academics were debating all that. That's fine. We've got to work out the framework for doing it. But once you know the data's out there, then you work out the control mechanisms, the quality mechanisms. It's going to be so cheap to store this stuff as well. We can put the whole UK genome on a server for about 70 petabytes. And don't forget, you've got about 2 in your head. So 35 people intellectually could store the whole UK's genome. It means you wouldn't be able to watch Coronation Street because you'd have no storage capacity. We can transfer a full genome in about 2 seconds as well. That's how long it takes. That's your genome, just being sent down a line. Then we've got to say the question, who's going to do it? Is it going to be government? The 100,000 Genomes project I'm involved with, they're going to look at 100,000 genomes. They've got £100 million to do it. But 100,000 genomes, that just barely scratches the surface. If you're going to look at everybody's genome, you're going to need a boatload of money. Is that going to come from private or public? Who's going to have the data? Who's not going to have the data? In neuropsychology as well, there's lots of things happening in terms of data, the power of data to diagnose people so you can earlier diagnose them. You do things like blood tests, and you can do things like spirometry, and you can do all those physical tests, but you can also do things on psychological testing, depression, anxiety, some of the big mental health disorders you can do, and you can analyze them by simple tests. You can do personalized diagnosis, and you can also do personal genome mapping. That's number 3, which will impact as well. It's very interesting. Looking at dementia and Alzheimer's. We've looked at about 213 compounds so far for treating Alzheimer's in clinical trials. I know because I see the data. And so far we've had 1 approved. Just 1. And why is that? Because the patients put into the trials weren't selected correctly at the front end. And that goes back to what the academics are saying about clinical trials. The clinical trial is only as good as the data you put in at the beginning. With the power of this sort of data, you can select the right patients, so you can select the right ones to go into the study. If we'd have done that 10 years ago, we would now have another 42 compounds on average for treating Alzheimer's, but we don't. That's what you can get from data. This can empower staff in hospitals to treat you the right way. The last thing is portable records. This is liberating. I'd mentioned that I lived in abroad for a while. There's my record. There's my health record. It's my Belgian health record. Every transaction I had with the medical system is on there. Every prescription I ever had is on there. On there are the links to my x-rays, which are stored in a cloud server. It's all there. If I get taken into hospital, first thing they do in Belgium is say, where's your health card? In it goes, into the reader. My records are there. They know exactly what's wrong with me. They know I'm colorblind. They know what medications I'm on. Don't tell me it's not achievable. It's about time to stop debating and start taking some examples from other countries who are doing it already. Stop talking, start walking. Do you know the top use for Evernote in the US is for actually storing your personal health records? 54% of Americans store their health records in Evernote. Yeah. So you're worried about secure systems? Do you think Evernote's that secure? No, it's not. They've got to move away from being records about me to being our records, my records about me. You can do things as well. If you start to make the records your records, you can also start to look at things like, should this person be entitled to receive care in this country? That's a dangerous one, isn't it? You can improve emergency care. You can move providers easily as well, because you know what you do? You pick up your health records and you go, I don't like you anymore. I'm going to go over here. Just like moving a bank. And that's exactly what happens in Belgium, and that's exactly what happens in France. Because if you don't like the provider, you pick up sticks and you move. Why hasn't it happened already? Why haven't we got all these changes? Basically, Newton's the guy. He had 3 laws of motion. The first one is the body will remain in the present status unless it acts upon it by a force. There's no force being applied. There is no driver of change. There's coming the brick wall, which is the cost. Because if we don't do something about it, we're going to hit the brick wall. We can try things like, oh, let's open our GP practices on a Saturday morning to try and improve availability. So we're tinkering with the supply side when we should be tinkering with the demand side. There's lots of areas like that you can talk about and think. Digital is the game changer. External drivers are pushing away. The technology is there or nearabouts, and the patients want it. Why should I be able to book my restaurant booking online and not get to see my doctor? Why not? Just answer me that question. It's not different. The medical profession is rightly cautious, but the possibility is enormous. They're not Luddites, they're concerned. We have to make sure the right force is applied to the medical profession and the payers so everybody shares in the benefits of it. Unless you work in a collegiate way and all get to see the benefits, including the patient, it just won't happen. And do you know what? It hasn't happened now because of that. That was fast, wasn't it? Yeah? Like a rocket. You're all glazed. Should I show the prisoner again? No, I won't. Good. I was going to take some questions if you want to. There isn't time?
There isn't time because everybody's moving between sessions. We started.
I kept to my time.
Oh, I know you kept to your time beautifully.
Okay.
We started a bit late, unfortunately, so there isn't really time for questions.
But I'm around for coffee if people want to grab me and just tell me what a load of rubbish I've just said. I'm happy to do that.
Okay. Thank you very much, Michael.